The home stretch here. It's just been a fantastic day. A lot of great speakers, and now we're going to have a practical panel discussion that three of our physicians are going to present. And let me introduce Dr. Nausheen Ahmed. She's Associate Professor of Transplant. She serves as Assistant Director for our Cell Therapy and program, Medical Director of the Transplant Survivorship Program for the Division of Hematologic and Cell Therapy at University of Kansas. She finished her hematology oncology training at Tufts and pursued advanced training in stem cell transplant at Case Western. She was previously faculty member at Cleveland Clinic and Case Western, and her clinical interests have been specifically directed at cell therapy and transplant for lymphoma, myeloma, myeloid malignancies, and survivorship. She's interested in studying the mechanisms of resistance in relapse in lymphoma, myeloma, post-CAR T, and transplant, and the role of maintenance therapies post-transplant. Her interests also include improving access to care and studying long-term effects of transplant and quality of life. Two of our lead community physicians are here today. Dr. Palmer is in Lawrence Memorial. She completed her degree medical school at University of Kansas. Her medicine residency was at Scripps in San Diego. How in the world she could leave that environment is beyond my understanding, but it's expensive. She did her fellowship at Wake Forest and currently is one of the lead physicians at Lawrence Memorial and a collaborator with our program, including in upcoming cell therapies. And Dr. Dalia is an attending physician at Mercy Clinic in Joplin, Missouri, in oncology and hematology department. He's a frequent supporter of our division, our program efforts on behalf of his patients. He sits on a number of editorial boards for clinical journals, continues to do clinical research with a focus on prognostic factors in lymphomas, viral associations, and hematologic malignancies, and performing meta-analyses. So with that, I ask him to come up to the table, and Dr. Ahmed will moderate the discussion, and I'll sign out here for a few minutes. Oh, am I in the panel? Well, there are only 3 chairs. No, you guys can do better than that. I've been talking all day. So you guys can all, Dr. Ahmed, you don't need to be on the panel.
Okay,
Do you?
just a tiebreaker, kind of. All right, well, thank you, Dr. McGurk. This is a very informal, just a discussion format, understanding better challenges to CAR T therapy, and we specifically invited Dr. Palmer and Dr. Dalia to understand perspectives from the community. Okay, so I'll just give a brief intro, and then I'll kind of, have them lead the discussion. Just some disclosure. So with CAR T therapy, it's a great advancement in hematological malignancies, but there's no great advancement if it cannot be accessed by the community. If patients can't get it, no matter how good it is, it doesn't work for them. There's many factors that go into limited access, and we know from some data that we have that maybe around 20 to 30% of patients who may be eligible or candidates for CAR T therapy are actually able to get the CAR. When we looked at this in some more detail, we know that there's disparities in particular groups that may not be able to have as much access to CAR T therapy. For example, females, older patients, African American population, patients with low income, insurance also has been shown to be a player in access, and then patients that live far from the treating center. These are some of the social determinants of health that define less access. And why is it important to look at access? It's important because even those that are able to eventually get to CAR T, we see that these social determinants of health can influence outcomes with CAR T. So there were some publications just last year showing that specifically with Axicell, overall response rates, CR and PFS was lower in non-Hispanic Black patients. And another paper showing that payer status affected survival for CAR T patients, with Medicare patients having higher survival. And in that paper, there was no difference based on race. But this is what people are looking into. And so how would it be that social determinants of health actually affect outcomes for patients that are eventually able to get it, but have lower responses with it? It's primarily, if you look at outcomes, it's driven by disease and patient factors, but also a big component of it is timely access. And there's many components that go into how does a patient get timely access to CAR T therapy. Here I've just identified a few, such as like referral delays or brain to vein time. What are things that can delay it when we're evaluating patients? Patients' hesitancy or other burden that prevent them from coming earlier. This is looking at it in another angle. This is looking at different stages of CAR T, at least the early stages, and what are the barriers that lead to delay in getting CAR T, if they get it at all. We talk about referral lag or bias, perhaps education gap, the distance from the treatment center, patient awareness, beliefs and values. There may be inadequate social support, no caregivers, financial burden such as out-of-pocket costs for travel, gas money, all of that, inadequate insurance coverage, and then when they do get here, then delays, in getting evaluation started, manufacturer delays and all that. So understanding that that's all in the picture, one has to also look at, when we think about access, we think about how the landscape is evolving. And while we have CAR T therapy as one of the, I would say performed really well and has changed the paradigm in hematological malignancies, we may also have other therapies that now probably compete with CAR T, and so will that make timely access even more difficult to attain? Would patients start going to bispecifics, for example, instead of coming to CAR T, and that would potentially delay or worsen their outcomes in the future? These are some of the questions that are coming up in our field. And so with that, let me just open the forum up here. I think that since we talked about bispecifics and how they could be competing with CAR T therapy, I just wanted to have a food for thought from our referral base. And I'm going to throw this question out here for the panelists. So for lymphoma, follicular lymphoma, DLBCL, if patients are eligible or fit for both CAR T and bispecifics, how would you choose one over the other? And I'll let you go. We have a CAR T proponent. It's going to be debate style. A CAR T proponent, bispecifics proponent, and then then the final perspective.
Is this on? I can't tell. Okay. So generally, I'm from Lawrence, so most of you probably know where that is. Go KU, Rock Chalk. But from door to our hospital to KU is about 40 minutes. And so I think most of the time we're pretty accessible, but when I talk to patients about going to KU and getting either a second opinion or going for treatment, they want to go one time, and that's it. And, it's hard to convince them to come up and then to discuss bispecifics versus, which are multiple visits and, depending on the interval of which bispecific you're getting, 1 week, 2 weeks, 3 weeks. A lot of my patients have had issues with that, and they're like, I really don't want to do that. Can I go once and get that done? And, so I usually refer for CAR T because it's a one very prolonged visit, or really several visits, but a one prolonged visit, followed by, with some follow-up. But they also, my patients like the idea that it might be, I guess maybe more curative than some of the bispecifics, although some of the data on that is changing as well.
And so my practice, so I'm in Joplin, Missouri, so that's 2.5 hours south of here. But KU is still our closest transplant center, transplant CAR T center. So, you know, one of the things that we have to think about with our patients too is, can they get a ride up to KU? Are they going to be able to make multiple trips up and back? With some of our ability to do video visits, that has helped tremendously for our patients and the team here. But we still have these conversations about, should we send you for CAR T? Should we send you for auto transplant when you have a relapse in this situation? Or should we think about bispecifics? And one of the pros for bispecifics is even if I can't give the first dose of the bispecific in Joplin, as long as the patient doesn't have many side effects with it, I can give the second, third, fourth, fifth dose of the bispecific in Joplin. So that can help our patients be able to at least maybe come up here once or twice and then get the rest of their treatment in Joplin and then have video follow-up with some of the specialists up in Kansas City as well.
Thanks very much. So I think that when we look at efficacy, which is really the bottom line, I don't think that bispecifics get any thumbs up there. I think you got one thumb up too many, because we don't know, we don't have 5-year follow-up to tell us any of those patients are cured. In contrast, we have 2 trials. One, the real-world data that we co-authored on almost 300 patients receiving axicabtagene in the 2017, half of 2017 and going forward, almost 300 patients, median follow-up of 5 years, and progression-free survival at 5 years, about a third of patients. And then more recently, we co-authored the submission of the data from Juliet, and there we see similar progression-free survival at 5 years. That has not yet been accepted for publication, but we've sent in the reviewers, our responses to the reviewers. So that's curative therapy for large cell lymphoma anyway. We don't know about mantle cell lymphoma or follicular lymphoma yet. And then when we look at overall response rates and complete response rates, and we stack up the available bispecifics against CAR T, specifically CARVYKTI, and I think Abecma's days are numbered, no offense intended for those who may be sponsoring Abecma in the room, but I think that's the reality. And 97.8% overall response rate in their report in the New England Journal of Medicine, stringent complete remissions of 82%. That's hard data to beat. And there too, we do see relapses, and we'll see when we have median follow-ups of 5 years, if there's a fraction of those patients, God willing, who are actually cured, but we can't say that. I can't give any thumbs up on that, and for that construct at this time. However, as our panelists were just saying, and Dr. Ahmed articulated as well, the logistics, and doesn't do having no access to CAR T is associated with a 0% chance of response and durability of response, and you do the best that you can where you are. Some patients, we hear from people from Joplin, from out at the Colorado border, from Great Bend, et cetera, they're just not going to the city. They're not going to go there, even if they have the means to go there and they can afford the gas and such. They've got a big farm that they're taking care of. They have business. They have kids in school out there and such. And so I think it's really incumbent upon us to take the magic out of CAR T-cell therapy. As we saw with, for example, the caribou construct, very little ICANS above a grade 1, 2, and no CRS above grade 1, 2, and a readily available off-the-shelf construct that can be taken out to community hospitals. To make these therapies more effective, we really need to be able to take them out to the community hospitals, and I think that will really be a game changer. In that regard, we are in discussions, and I can't talk a lot about it right now, with the FDA meeting several weeks ago, a meeting coming up in 5 weeks about consortium approach that will spearhead here at University of Kansas, be a national trial of taking CAR T-cell therapy out to the community. Peter Marks, until 3 weeks ago, the head of the FDA, suggested that the way to get a successful registrational trial and FDA approval is show that you can do this in the community. And for all the right reasons, that's the road that we're going down.
Any other comments on that?
Yeah, I was going to say the other thing I think that is important just with partnerships between like academic centers and community programs like ours is just like open communication. So this is the one thing that we do really well with KU is that, we're texting the physicians up here. We're talking to them all the time to make sure that our patients are taken care of close to home so that we don't have to, have that patient come back up here as often, which I think is key because there's a lot of centers across the country that don't do that really well. And when they don't, then we don't know what they're doing, they don't know what we're doing, and then at the end of the day, the patient, I think, just suffers in their care.
Or even worse. So I want to tell you about a situation that stuck to my ribs and always will. When I went to Yale, I had trained there, and I went back there after my fellowship training and such. And I was directing their allo transplant program, and so going out to community practices in Connecticut and introducing myself and hearing their concerns and letting them know that we would be there for them. I had one of the private docs say to me, okay, so I send my patients up to Yale, and it's an abyss, and our patients disappear into the abyss. And he said, I was at Walmart, and I ran into the spouse of one of my patients. I hadn't heard anything for 3 months. I ran into his spouse at Walmart, and I inquired about, how are things going? How's he doing? Well, he died 2 months ago. Okay, and the academician in the ivory tower didn't have the decency to pick up the phone and call the referring physician and let them know that that happened. That's absolutely unacceptable. It's a horrible outcome. And so, for our center, and it's always in need of improvement, we strive for perfection. We'll never get there, but striving for it makes a difference to patients, their families, our referring physician colleagues in the community. And that is your attitude to referring physicians, their practices, their teams, patients and their families, and your team members at KU is yes, sir, yes, ma'am, right away. Can-do attitude. And also, all of our attending physicians, when they see a new visit, I've told them and set the example that don't go see the next patient until you pick up the phone after you've seen this referral and call the referring physician and let them know what you're doing. Otherwise, you put it off to the end of the day or you'll forget about it, won't get done. Always do that 100% of the time. You can never go wrong. And when patients are going back to, and this is an area actually in need of improvement in our program, when we've done an auto transplant, for example, or a CAR T, and they're going back to the referring practice to pick up the phone and talk to the referring doc so they don't get blindsided and this patient shows up in their clinic the next week. That still happens sometimes. It's unacceptable. And it's not safe because we're seeing, for example, with CAR T-cell therapy for myeloma, neurologic toxicity that may not occur until many weeks or months after we've employed that. And if you don't give the physician and their team a heads up on that, shame on you, and they get blindsided again when they show up in the emergency room with Parkinsonian-like symptoms and such. So it's all about communication. That's absolutely right.
Yeah, I think we have a comment.
Yeah, thanks. I'm inserting myself into the panel to make a comment, so that I hope that's okay. All right, so we face the same challenges in Boston. Sort of like our patients from Maine who refuse to drive into Boston. I find that odd, but that happens. And so, but might I say we take a step back and say this, just to frame this, is that this has to happen. Okay, so spread of CAR T or cellular therapy in general to the community has to happen. And why is that? because cellular therapy is just coming. We all know this, right? And even though all of the approvals right now that have what we believe to be a large volume, which is not even close to a large volume, are oncology specific, what we deal with in blood cancers. Once we get a true solid tumor approval in addition to TILs or not worse, or more frightening, a non-oncology indication, we're all going to be overwhelmed. So there's no way that we can continue to keep these in academic medical centers. It's not about, no offense to the debate, it's not about CAR T or bispecifics at the community. It's about how are we going to handle the onslaught of volume, right? We as oncologists or transplanters, whatever you want to call it, we're only in control right now of the resources because the indications are our patients. Once you have a solid tumor or a non-oncology indication that overwhelms anything we do, either we do it right and have found a way to do it, or we're not going to be in control, and then we're going to be told you can't transplant your next patient because we have 10 multiple sclerosis patients that need this therapy. So ultimately, I think that's the challenge, and I think centers that have a transplant program already, it's obvious they have the infrastructure, they're able to do it. It's centers that have the clinical expertise but don't have any of the other infrastructure that you need, right? Our system's broken because it's not like companies that came up with these therapies said, oh, here's a system, why don't we sign an agreement with every individual hospital that we're gonna onboard this cell therapy for? And that's insane. I mean, the amount of backroom work that it takes to onboard and give the next cell therapy that comes is a non-sustainable process that we unfortunately have created. So ultimately, we need to find a solution of and the first step is to take CAR T to the community. So that's the test drive, because the next therapies that come, that's going to be the stuff that overwhelms us.
Thank you. Yeah, completely agree. So, we had a bit of a case scenario here, but in the interest of time, I'll just go on to the next question. We published some data with the consortium, the Lymphoma Consortium, looking at lysocell, tisocell, and axicell. Seeing, right now we have a requirement of the patient needing to stay 4 weeks within, it depends on every treatment center, within a certain distance. In our center, it's 30 minutes, within 30 minutes of our treating center. For 4 weeks, and then after that, and no driving for 8 weeks. And that's, that was part of the REMS, and then the REMS has changed, and then now it's part of the product labels. What we suggested was that a flexible monitoring period beyond 2 weeks might be safe because you don't see a lot of CRS and neurotoxicity beyond that. I mean, they're still at a risk of infection. They still might have cytopenias. There's still other things that could go on, but the REMS and all of this was initially in place for CRS and ICANS, and that was why we specifically looked at that. So I wanted to see, based on that after 2 weeks, usually the lower, the higher grade, I should have said higher grade ICANS and CRS is pretty rare. Frequency being less than, I'm generously putting 5%, but it's probably less than 1% across the currently approved CD19, that's lysocell, tisocell, and axicell, and also BCMA products. We had another, we looked at that as well. So I'm going to ask our panelists now some questions. Do you think that a hybrid model or shared model in which earlier transition is possible, would that back to your service, would be better for patients? And also, is it feasible? Like in general, what does it sound like?
I absolutely think it would be better for patients. Even from Lawrence, staying up here for 30 days. Is a lot for them. Where do they stay? How do they deal with their, children, or if they care for grandchildren? What if their spouse is trying to work, and they find it difficult to commute? Lots of questions have come up, and I've heard, some legitimately, really interesting logistics that have, patients have done to manage their CAR T, and I've heard some patients, and I know some patients who just can't manage it. So I think this earlier transition back to primary oncology practice and back into their homes would be better for patients. And I think it's feasible, as long as we work together and, I know what to expect with these patients, like what are the chances of them having a late toxicity, or, you know, what kind of infections do they get? What do I need to be monitoring them for, you know, more closely? And I think as long as we have an open line of communication, we can make that work and provide better care for them.
Yeah, I would agree. I mean, I kind of think about this as like the early days that we had in melanoma for Opdivo and Yervoy, or Yervoy alone when it first came out. Everyone was scared to death to give the drug because of the diarrhea and people dying from diarrhea. And then once we kind of got guidelines on how to manage these things, it was a lot easier for everybody to take care of these patients. So I think it's very safe to send a patient back to a community practice. I think you just need a physician champion in that community practice who really knows, okay, these are the suspected toxicities I'm gonna have to go to. So if one of my partners needs to come to me and say, what do I do in this situation, they can. And then we have an open line of communication with people at KU or elsewhere. And if that's there, I think most of the care is gonna be pretty easy for us in a community setting. And it's a lot easier for the patients to come and see us 3 times a week than to drive up to Kansas City to do it.
And absolutely, Dr. Chen is absolutely right on the mark, and I know we all completely agree with that. We don't have a choice. It's simply not a choice. The timing is a choice that we have, and when do we start rolling this out? And my take on that is we better get the show on the road here and start rolling it out, because again, when we start having hits in solid tumors and such, we're treating relatively rare diseases, right, among the cancers. We're not treating the heavy hitters, breast cancer, colon cancer, pancreatic cancer, prostate cancer, and those are the ones that our solid tumor oncology colleagues, in collaboration with us in our cell therapy program, are treating right now with T-cell receptor modified constructs, NK constructs, CAR-T constructs. There are a lot of challenges there. There are scientific barriers and challenges, but men and women in laboratories throughout the world community, and certainly in this country, are knocking those down one after another, and those barriers will fall. And when they fall, if we already have an infrastructure in place where we have some time and we can pace ourselves and we can show the FDA that we can do this in hematologic malignancies very safely, efficiently, and more cost effectively, especially with allogeneic constructs, and improve access for rural populations, socioeconomically disadvantaged, racial and ethnic populations who are underrepresented, then we'll be set up for success when this starts really being a large volume.
Any other comments from other centers? Yeah. Sounds like this would be something in the future, to get, one of the many solutions that will probably come out there to get CAR-T more accessible.
It's my job to keep us on track.
Yeah, we're good.
We're 3 minutes over.
We're good. We're good. Thank you.